Thanks, everyone, for being here when there are numerous options in the course of a Thursday afternoon. Today is Social Determinants of Health and Substance Use, and on behalf of the App Foundation, I welcome you to this latest community forum. These are places where folks on the clinical side, perhaps social work side, folks with lived experience can all come together and with curiosity and insight and questions for an expert such as Dr. Oluwole Jegede, whom we are very fortunate to have here with us today. Dr. Jegede is a psychiatrist in New Haven who subspecializes in addiction, community, and neuropsychiatry. He is affiliated with the Connecticut Mental Health Center, Veterans Affairs Medical Center, and Yale New Haven Hospital at Bridgeport. He's received his education from the Yale School of Medicine, George Washington University, and the University of Ibadan in Nigeria, and has been in practice for over 15 years. The Apt Foundation is very fortunate to call him their doctor, one of their doctors. And so, Dr. Jegede, I will turn it over to you.
Thank you, Eleanor, and thank you to everyone here. I'm so excited to be back at our foundation. Just a little more context, I did my addiction fellowship at Yale School of Medicine, but my primary location was at our foundation. So I feel like I'm back home, and I'm just so excited and happy to share at this forum today. And thank you all for coming. So today we'll be talking about social determinants of addictions and addressing inequities, social determinants of health, particularly amongst our populations with substance use disorders. I have no conflicts of interest to disclose. Learning objectives. By the end of this forum, participants will be able to identify social determinants of health as risk factors for addiction, compare the concepts of inequality and inequity, describe causal pathways from social factors to addictions, identify racism as a structural determinant of health, describe policy and clinical initiatives to address inequities in addiction. What are social determinants of health? These are non-medical factors that influence the health outcomes of people with substance use disorders. They are the conditions in which people are born, they grow, work, live, and age, and the wider set of forces and systems shaping conditions of daily life. But social determinants of health are also stratified into social hierarchies that determine an individual or group of individuals' exposures to health vulnerabilities. And I'm going to talk about that in a little bit, talking about vulnerabilities. But traditional paradigms in healthcare have ignored social causation and focused mostly on biological modeling of disease causation. Like when we were in school, we were more focused on, the biology of diseases and not necessarily on the social underpinnings that underlie most of the conditions that we treat. This chart is from the United States Department of Health and Human Services, Healthy People 2030. But they grouped social determinants of health into 5 categories: education access and quality, healthcare access and quality, economic stability, neighborhood and built environment, and social and community context. But the way I want you to consider this is to consider it along a complex continuum of interrelated and interdependent categories, and not just as standalone. They work together. It's a complex system that interact with each other. Social determinants of health have not always been a very popular topic. What I did was I went on PubMed and I did a little search around social determinants of health to see how researchers have been pushing out research around social determinants of health. In the year 2000, there were only about 2,400 publications. By 2022, just last year, there were over 38,000 publications. Somebody is paying attention to social determinants of health. Now, a very useful way to begin to conceptualize and understand social determinants of health is to think about its theoretical frameworks: psychosocial theory, sociopolitical causation of disease, ecosocial theory, and related multi-level frameworks. Now, this helps us understand what we're talking about when you consider that psychosocial theory basically puts emphasis on people's experiences of their position in unequal societies, leading to stress and poor health. And this is what we talk about in America when we think about social determinants of health, is we're looking at what are structural racism, and we look at how people experience their position in an unequal society like ours. In the UK, actually, they were talking initially about social-political causation of disease, which they're thinking about stuff like income inequality as being the main basis of health disparities. And finally, you look at the Krieger's ecosocial approach, which is a multi-level framework that integrates all these theories together. One thing you would notice very quickly is each of these theories have a social component to them, whether it's psychological, whether it's social, whether it's ecological, they all have the social component, and it's very important to consider social factors when you have your patients right in front of you and in the community. It is very interesting how we have framed social determinants of health over the last couple of years. Paula Braveman, Egerter, and David Williams wrote a book, and they talked about upstream and downstream factors. Now, when you have a patient right in front of you, the conditions you see, the behaviors you see, the proximate characteristics of your patients are basically downstream determinants. You know, you're looking at substance use, maybe relapse, treatment dropout. Those are the proximate factors. They are downstream determinants that are being controlled by upstream factors, much more distal factors that are much more difficult to control, but nonetheless affect downstream determinants of health. By that, we're looking at economic and social opportunities, living and working conditions of your patients. So when you're thinking about social determinants of health, it's very helpful to consider it upstream and downstream. And that brings me to a chat that was put up by the WHO, that's the World Health Organization Commission on Social Determinants of Health. Again, you see here socioeconomic and political context as the upstream determinants of health. But I want to center here, if you look at this chart, which is a little bit busy, you will see social class, gender, and racism, which we don't talk about a lot in terms when you're thinking about social determinants of health, but nonetheless, very, very important. So I want to center that here as one of the key things that affect our structure, that affects our patients, is racism and impacts health equity and well-being through these intermediary determinants of health. If you can see my cursor here, including material circumstances, behavioral and biological factors, and psychosocial factors. But this would have been nice and dandy, you know, if we didn't understand that there is an intergenerational transfer of disadvantage. The negative impact of social determinants of health accumulates over a lifetime. And unfortunately, those can be transferred to one's progeny and future generations. Okay. And when we talk about intergenerational transfer of a disadvantage, there's also intergenerational transfer of advantage. This is from one of the work that I'm doing currently with Dr. Jordan. And we're thinking about what are the pathways from social problems, from social factors to substance use disorders. It is not only enough to think about it as the fact that social factors just affect substance use disorders. In fact, it is reasonable to consider social factors as etiological to substance use disorders. You know, we're talking here governance, public policies, structural racism, acting through modifying factors of homelessness, housing instability, built environment, education, food availability, transportation, poverty, inequality, acting through pathways of biopsychosocial pathway, you know, through the stress pathway, causing and perpetuating substance use disorders. But again, I also want to tell you here that these factors are non-mutually exclusive. They're mutually reinforcing, they're codependent and co-exacerbating. And then you ask me, Dr. Jegede, why are some people at a heightened risk of adverse outcomes? And I have an answer for you, and that is structural vulnerability. Structural vulnerability is an individual or population group's condition of being at risk of negative health outcomes through their interface with socioeconomic, political, and cultural hierarchies, meaning the way your patients interact with the system that we've created, the healthcare system, puts them at a structurally vulnerable position. And then leads me to my next one, which is the location of your patient, their perceived location within a system that we have created constrains their access, their ability to access healthcare and to pursue healthy lifestyles. So that's structural vulnerability. And we'll still talk about this as we go ahead. This is a chart I believe you've all seen before, and it helps us really center equality and equity. These are guys who want to just see the game. But as you can see, they have a barrier ahead of them. Now, the barrier is the same height. But you can also see that these are young men who are also vertically challenged. Now, what we did in this case was we provided them what we would consider as an equal opportunity. But we have to do more than this because we need to consider basically the individual characteristics of each person so we can provide the help they need. So we have to begin to move from just equality to equity. For example, it's not only enough for us to codify telehealth services in addictions. You know, when there are people who don't have smartphones, if they have smartphones, they don't know how to operate it, you know, or to say every doctor or every PA or every nurse practitioner should, you know, prescribe buprenorphine when all of us want to work in the Manhattan's Upper East Side. Then who's going to take care of the people in inner cities? So we have to provide equity, equitable care, and beyond not just equal care. Now, in 2003, the Institutes of Medicine prepared this great document to sort of center racial and ethnic disparities in healthcare. And I want to read to you two of their conclusions. They said racial and ethnic minoritized populations tend to receive a lower quality of healthcare than non-minorities, even when access-related factors were controlled. Now, this blew my mind. Now, regardless of access to healthcare, minoritized people still had a lower quality of health. So now you wonder why. The reason is in the second bullet point: financial and institutional arrangements of healthcare and the legal and regulatory policy environment in which they operate have disparate and negative effects on the abilities of Black and Brown people to attain quality healthcare. But our healthcare systems really reflect our culture. You know, it's not accidental at all. It reflects our social intention and belief. Think about the war on drugs, the preference for abstinence-based moral failure treatment that we have created in this country, which continues to think about the wait times to get into treatment. It's about average of 30 days in this country. If this was some other specialty, if this was for diabetes or for hypertension or one of those, it would be real outrage. But because we've created a system that's allowed this culture, and we have created it, it's intentional, you know, so we have to keep this in mind and know that the treatment is set up in ways that lead people to not access care or not remain in treatment. How does inequities manifest in addiction? One, the prevalence of drug overdose has been rising the fastest among minoritized populations. Black and Brown people are more likely to be involved in the carceral system. Minoritized people are less likely to engage in addiction treatment, initiation, and maintenance. And African Americans and Latinx people are less likely to be treated with buprenorphine, like I'll show you in a minute. And also, our patients on methadone are more likely to navigate the trifecta of stigmas. One, of their race, two, of having an addiction, and three, of being on methadone. A very interesting study here that really looks at drug overdose deaths between 2019 and 2020. And then they looked at it by the social determinants of health, the picked income inequality ratio. What they found was that the more unequal a county is, the higher the number of overdose deaths, right? The more unequal a county is, the higher the overdose deaths. And as you can see, for American Indian and Alaska Natives, it didn't matter. Even despite the disparity, the income inequality ratio, the overdose deaths was still through the roof. And this is really a case that happened around 2019, 2020, which is around, it's even worse now where you consider the COVID-19 pandemic. The disparities is increasing amongst minoritized people. But race is not the determinant of health. Racism is. Race, like you know, is a social construction that has morphed into a pseudo-biological reality with significant health implications. Racism, you know, is a weaponization of social structures. Structural racism really is baked into our historical foundations as a country. Now, in addictions, racism in addictions or in the substance use disorders dates back for very, very many years ago. It goes beyond the Harrison Narcotic Act. Dates far back as 1880 with the Angel Treaty in response to anti-Chinese sentiment. But I want to point your attention to a contemporary one, which is the Comprehensive Crime Control Act of 1986 and 1988 that established 22 new mandatory minimum sentences and the 100-to-1 crack to powder cocaine sentencing disparity. Basically, the way to think about this is you're going to get a 10-year mandatory minimum if you have a chocolate bar of crack cocaine compared to like a briefcase of powdered cocaine. Just because, you know, the racism that thinks that, you know, black and brown people were more likely to use crack and white people were more likely to use white powdered cocaine. And then, but the same sentencing for both of them. Now, how much disparity can you ask for when you think about this? Still talking about structural determinants here and the way that we have depicted Black and brown people with substance use disorder. This is just some of the pictures you think about when you're thinking about substance use disorders in our communities. Now, I pulled up this recently, and I thought I changed it, but I was surprised to see that they haven't changed it. You can already see the marketing of buprenorphine to specific categories and demographics of people. And you will see in my next slide is buprenorphine as an example is being marketed, you know, to people, one, who are white and people who can pay for it, you know. Now think about this. In this JAMA Network article, buprenorphine treatment divided by race and ethnicity, the researchers found that if you were white, you were more likely to be prescribed buprenorphine. Also, if you had private insurance or self-pay, you were more likely to get buprenorphine. In the meantime, you know, methadone is being heavily stigmatized. 78% of your patients on methadone experience stigma, according to this study. Okay, and then the stereotypes they're content with is number one, people, the community says they're using methadone to get high, they are incompetent, they're untrustworthy, they lack willpower, and they also have multiple stigmas. Helena Hansen talked about this in her work that shows that buprenorphine treatment rates were highest in New York City in the social areas with the highest income, and lowest in the percentage areas, in the lowest percentage of buprenorphine treatment in Black and Hispanic residents live. Conversely, the methadone treatment was highest in the social areas with the highest percentage of low income and Hispanic residents. Now, it is not enough to talk about these problems. What are some of the interventions? What can we do? Okay. Social determinants of health are very difficult to measure, okay, because we don't have sort of a general uniform system that we can use to measure them. But I'm showing here some of the things we can do in our practices, in our community. There's the protocol for responding to and assessing patients' assets, risks, and experiences. There's a social needs screening tool from the American Academy of Family Physicians. There's the Accountable Health Communities Health-Related Social Needs Screening Tool, and there's a Structural Vulnerability Assessment Tool. However, I want to point out here that social determinants of health is not just a number. So we don't want to reduce our patients to numbers and say, oh, you have a social determinant of health of 5 or 10. Or it's a very complex system that would take understanding the community and talking to people, and also will require structural change. And when we talk about change, we need to talk about multi-level intervention to address disparities. Single-level interventions are limited in scope and approach. We have to sort of think about the socioeconomic framework and address more than one aspect of it: interpersonal, organizational, community, and policy. We have to address all these nodes in order to make any meaningful impact in addressing social determinants of health. In changing the framing paradigm, we have, first of all, to acknowledge that disparities exist in addictions. We have to deliver culturally sensitive care and center anti-racism in our clinical care and in our addictions research, and programmatic efforts to improve racial equity in the addictions is really, an addiction workforce would be a real good way to start racial justice. Now, in rounding up, social factors determine health outcomes in addiction via several complex interrelated pathways. And I've told you that those pathways I found very interesting because they are ways I think we can intervene. If we think about it from social factors to addictions, what is the pathway? And then we can intervene. Health outcomes in addictions are related to the location of individuals on a hierarchy determined by political and economic forces. We require multi-level interventions to address social determinants of health. Single-level interventions don't work anymore. We have to address more than one aspect of social determinants of health at a time. At every level, we must recognize structural factors as the main drivers of poor health outcomes in our patients with substance use disorders. And that is all I have for you today.
Wow, Dr. Jegede, you've taken us through such a wealth of material and in a very short amount of time, for which we're very grateful. A few different questions came in. The concept of spatial justice pops up here and there in discourse, and I suppose that relates to in some ways to the racial segregation that residents of a city may experience, and that, I guess, is one of those complex layers. Or do you think it's one of the most important ones? Or how do you tease out, the spatiality of this in terms of different neighborhoods?
So this is very important, and I actually did have a slide on it, but for time, I edited it out. Thank you for bringing that up. Yes, when you look at racial segregation, it's quite a big deal. In fact, there is a correlation between racial segregation and, guess what? People who the intravenous drug use in the community. There's research around that. Think about redlining, how the redlining of the 70s, how it's affected us till today, and not just in psychiatry, even in things like other medical conditions like asthma. The redlining has been a really major issue. And yes, racial segregation is responsible for a lot of social determinants of health that we see.
I suppose to the extent that certain risk factors are concentrated in certain areas, then you imagine, young people looking around and seeing, things on a higher frequency, and that also is a social factor, how people grow up, what they see.
Also, talking about location, we have research now around transportation, and the location of services and communities.
Ooh.
That's also something we need to think about, is where are your patients coming from? Are they able to afford transportation? How often are they coming to clinic? Things of that sort, So that's another aspect of location that's very important. Another thing is how they perceive themselves in sort of a special, in the society. How do they perceive themselves on a spectrum? Where are they? on an economic, on a social spectrum, and an economic spectrum, how do they perceive themselves? What we find is people who sort of perceive themselves on the lower end of the spectrum, they just have a much more difficult way to navigate the system, either because they have poor education, they live in a poor neighborhood, or they have a low socioeconomic profile. It just so happens that they have a much more difficult way to navigate the system, and they have poor health outcomes.
We have this question: what type of research do you think is needed to improve programs? Is it a matter of more research or specific research questions being refined, or?
We have, so research in social determinants of health have taken off over the last few years, but it's still all over the place. We have to speak the same language in research. So to the extent that we can compare results, now people are using big data, they're using simulation models, they're using other things to just understand social determinants of health better. Like I said, this is a very complex. For example, you're thinking about homelessness. Let's pick homelessness as an example. Homelessness does not begin to talk about everything we mean. Do you mean stable housing? Even though you're not homeless, is that stable housing for you? Somebody may be living with a family, and that to them is unstable. So we have to speak the same language in research. Another thing is just the structure. The structure of our communities need to change. This would take political will. It's not just research here. It would take political will. It would take all our organizations centering anti-racism, in our systems. It is an understanding that people are, that social factors just have a very, almost as important as biological factors in talking about health outcomes.
So the best practice you've suggested near the end is to approach every individual as a combination of their location at this point in time and then their location within these hierarchies.
Absolutely.
Yeah.
Absolutely.
How do you think the Abt Foundation's open access approach addresses these issues?
So I knew that would come up. So, and the reason I say that is our foundation occupies a position in this community that is enviable. It is so, since I left the Abt Foundation, I've seen in the community how people talk about our foundation. Like when we're in other clinics and patients come in and they want to, they have issues, we don't know where to send them. We know that our foundation will accept them without judgment and without wait times. That is very, very important. And that should actually be emulated by other programs, which is open access model. It's a way to bridge a very interesting gap. I don't know how to say, but that is really a key. Our foundation open access model is one of the ways that we can begin to address structural determinants of health, in our communities. Because of the long history of racism in this country, people don't trust the system. And the system is not accidental, like I said. The system is absolutely designed to give us the results that we're getting, that people don't engage. And when they engage, they don't, they drop out of treatment. Open access model, for example, presents a forum where people can come in and they're welcome, and then we can begin to address some of these issues. But thank you for the question. It's a great question.
Yeah. Before we put the call on live, we were talking about COVID and some of the effects of COVID, and it strikes me that one of our speaker on the Abt podcast, Dr. Robert Heimer, was talking about how the state changed their regulations during COVID. It was an interesting kind of experimental lab to say, yes, you can take more bottles at one time just because it's more practical for everyone. And they looked at, did that increase the likelihood of overdose? And it did not. It looked like people were safe and responsible with more bottles at one time overall. And that was a very interesting finding, because then you've got less less times to navigate a lack of transportation or, all of those different things.
And it's changing. Thank you for bringing that up. That's changing the dynamic of methadone treatment in this country. Hopefully it does. That's if, I hate to say that was a positive thing that came out of COVID, but indeed, methadone is going to change. Currently, I know SAMHSA has proposed that these changes be made permanent, and that's very important. Methadone to me should be seen as any other medication in medicine, and should occupy its right of place, like buprenorphine or one of the other medications in addictions. But yes, you're right. And not only is it that we're talking about take-home bottles and stuff like that, it's also the presence of other substances in the urine toxicologies. Now, before, in some states, once you're positive for things like cannabis, you lose your take-home bottles, you're penalized in some way or another. But that is also changed in the context of COVID, and I hope these changes are made permanent, because, like you said, there was no issues with overdoses or people misusing their medications, and COVID was just a sort of it presented a platform for us to test these very interesting ideas. And I hope they're permanent.
Yeah, a lot of the underlying assumptions got challenged, and yeah, interesting.
Another thing is just when you talk about buprenorphine now, the X waiver is off. Anyone with a license, physician, nurse practitioner, or PAs can prescribe now without the X waiver. That's also another thing that is very interesting. And also telehealth services. This is another thing that also came out of COVID, and hopefully it changes the way we operate around substance use disorders.
We have here, you mentioned from Ahmed, you mentioned racism and stigma as being barriers to improving public health. Do you think addressing inequities with data and as a healthcare issue, not a social one, would help with implementation of targeted initiatives to improve treatment? Perhaps stigma racism will not improve as fast as we need to see immediate results.
Thanks, Ahmed, for the question. If I understand your question, could you unmute and...
Yeah, sorry, I know it was long-winded. How you doing, Doctor?
Sure, thank you, Ahmed. Thanks for the
presentation. Yeah, so what I mean by that is when you start talking about specific populations that are suffering and vulnerable in this type of social political environment, it kind of gets marred within a pushback from the dominant culture and or class. So do you think if you utilize things like things that are that kind of speak to the reality of the situation without race attached to it or economic factors attached to it, even though they are there, and you present it that way, do you think you may be able to get more traction on initiatives? Because I think we live in an area where folks are like-minded for the most part, but not all parts of the country equally are as accepting of these realities as others. So I would just want to get your perspective on that. And that's kind of what I mean. Because regionally, you may find more folks more apt to try to do more health initiatives for people who are suffering from OUD, who happen to be African American, who happen to be Latino, who happen to be from low socioeconomic status. But in other parts of the nation, you may not find the same type of advocacy. So I was looking at it from a perspective of how you present these realities in different settings where you may not have such an active audience, to take in the information and to move initiatives forward.
Thanks, Ahmad. I think it's a great question. But the way I'll approach it is I want us to see racism more as structural racism, systemic racism, which goes just beyond the interpersonal racism, which is what we think about when we think about racism, to a more structural one, something that is quite embedded in just the system of the way we operate things, sort of over time. Things are the way they are now because of the structures that have been put on the ground. You see what I mean? So the fact that Black and brown people don't want to even access treatment, for example, could be linked to structural racism. Not things happening now, but things that has happened before. You see, which has already like sort of set up the way our systems operate. But yes, I agree with you that when you think about anti-racist communities, what you find is you're more likely to access care in those welcoming settings, okay? And more racist or less anti-racist settings, your people like us are much more difficult to access access treatments in those settings. So think of racism as in a structural way, in a systemic way, something that affects all of us, even if you're not directly involved one way or another. For example, I told you about how intergenerational transfer of disadvantage, you may not even know, but the pathways from structural racism or structural factors to addictions may be stress. The stress from just hearing about this another school shootout, the stress of another Black man is being shot, the stress of just living in a society that is absolutely unequal. And there's a lot of data on this, particularly in Europe, talking about when you have communities with very high income disparities, what you find is more mental illness. What you find is more substance use disorders. What you find is people are just not accessing care, So the more the racism, the more unequal societies are, the more you see this dysfunction.
Thank you for your answer. Yeah, in that context, it makes more sense. Yes, I was looking at racism not from a limited standpoint about one-on-one, maybe from an advocacy standpoint, not from a structural standpoint, which is, the broader context, makes more sense. So thank you.
Right.
Thank you so much. It is a vulnerable conversation in some ways, and to, be able to exchange questions and curiosities is a really important part of meeting our learning objectives.
And, I also think it's important for us to have these conversations. They're difficult to have. And if you know one of my slides, I said, we need to identify and just acknowledge.
Right.
We need to acknowledge these problems
Right.
as the first way to deal with it. So they're very difficult conversations to have, but we need to have them nonetheless.
Thank you. So the question came in that if the open access model that the App Foundation uses is helpful, what is stopping it from being replicated more often? What are some of the barriers to really having this spread like wildfire if it's so helpful?
It would be a great question for Lynn. That's the CEO of our foundation. But yes, it's when I first came to Connecticut, it was new for me as well, and I know there's been data on this. Lynn has worked with a few other people that published data on their outcomes, and the outcomes are great. But I also feel like one of the successes of our foundation is the people that make up this organization, the people at the top who lay down the pathway to make this happen, and then the people who then eventually do the work. We just have to keep advocating for this model to really be the model of substance use disorders and addiction. I think it's a great one.
So like so many things, it's the visionaries that have to kind of wait for the world to catch up and keep pushing in the meantime.
Yes, and then we also need to disseminate more research based on the open access model. And not only research, but also policy people, and make them see the need to sort of expand these models of treatment, these models of care. Stigma is one thing we have to think about, particularly around methadone. And it's really talks about the history of methadone, how we started using methadone for opioid use disorders, and how it's been stigmatized and racialized from the get-go. I think as healthcare professionals, we have to think about how to, in fact, destigmatize methadone and put it in a position where it is a legitimate medication for opioid use disorder, you know. So understanding the stigma around methadone would also help us engage our patients in a more humane way. And on the policy level, I think there still has to be a lot of changes around methadone. Hopefully we're getting there. But Canada, Australia have done certain things around methadone that to really destigmatize methadone. We need to do the same.
Well, others have mentioned that for a chronic relapsing condition, such as substance use disorder, problematic substance use, we're still somehow surprised by relapse, whereas, you know, or punishing towards it in some settings, whereas, you know, you wouldn't think to withhold hypertensive medicine to someone because they're eating salty potato chips one day. And yeah.
Or insulin from someone with diabetes is if they're having a beer or whatever. And this is important, you know, and it goes to what I talked about, the wait times. The wait times for us to get into treatment. It's about 30 days. It would be outrageous if this was, you know, diabetes or cancer or one of those, you know, and somebody with substance use disorder can't wait.
Right.
You know, because unfortunately now in the era of fentanyl, who knows, you know, you can't wait. You need treatment, you need it right there. And it needs to happen. But because we have a system that is very intentional about punishing people, even if they don't know it, this is what we have. 30 days wait times to get into treatment.
3 hours, I think, is what Aptus managed to get it down to. So
That's unbelievable.
Yeah.
Truly unbelievable.
Something that we can be very proud of in the greater New
very
Haven
proud of.
community to have that. I guess we're going to wrap up for today, and we'll be happy to cross paths again as this conversation unfolds.
Absolutely. Thank you all for coming.